Hi, a very good evening, all of you. Welcome to our session 10. I think it's session number 10. So please confirm the audio and video streaming. If everything is fine, then we can go ahead with that discussion as usual. So beginning of the week, I hope you're all pumped up and looking forward to this entire week. And you have any queries, you need any assistance or guidance from our side, always feel free to get back through mail 24/7. Right? So I think the audio is streaming fine, video also. Everything is awesome, right? A very good evening, each and every one of you. Welcome to our 10th session, case-based discussions made easy. I hope you guys are all ready. And before we start, the objective of this session is to enjoy the learning process. Learning is fun if we're doing it in the right way. And if learning is not fun, then what's the point in doing it? So with these objectives, let's go ahead and also in the process, make sure that you're maintaining a customized notes, right? And this customized notes is going to help you save time, especially before your entrance exam, giving you accurate, customized information and also enhancing your confidence. So never ever underestimate the potential or the power of a customized notes. I'm not talking about any ready-made study material, but your notes, the notes which you prepare through active participation and engagement. So without much delay, so let's go ahead with our presentation, and here we go. So as you know, we have crash course and Mission 12 batch, new 2 courses going on in our academy. You can find out all the details in the website ptbdacademy.com. So crash course towards NEET MDS 2022 and Mission 12 batch, a 1-year batch towards NEET MDS 2023. So here is the case. Here is today's case. A 31-year-old HIV positive male patient visits a clinic with a chief complaint of ulcer on tongue. For several months, he has no pain, and on clinical examination, you notice enlargement of submandibular lymph nodes. Upon further inquiry, patient reveals that he is having headache, fever, and stiffness in neck. You refer him to his physician, who advises some tests, and the results are as follows. So before we look into radiographic presentation and also lab analysis, I want you to go through this context or case carefully once again. A 31-year-old HIV positive male patient with a chief complaint of ulcer on tongue for several months, has no pain, but just comes because he has this ulcer. He's worried. So you notice upon clinical examination, one of the signs is enlargement of submandibular lymph nodes. And upon further inquiry, patient reveals that he's having associated or other chief complaint, like he thinks it's not related to this ulcer, or is it? So that is our job to find out. Upon further inquiry, patient reveals that he is having headache, fever, and stiffness in neck. You refer him to his physician, who advises some tests, and the results are as follows. So before I go ahead with the results or radiographic presentation, I hope the context is clear. So observe the areas which are highlighted in red. Age of the patient is HIV positive with a chief complaint of ulcer on tongue, and sign. One of the important signs which we mentioned here is enlargement of submandibular lymph nodes, and other clinical manifestations or clinical symptoms like headache, fever, and stiffness. So this is the context we have. And on left side, you can find chest X-ray. You can see diffuse radiopacity, and also you can find bilateral hilar enlargement. So these areas, right? So you can find this opacity, you can find this patchiness bilaterally. This is a chest X-ray, right? chest X-ray of lungs, you can find bilateral infiltrates. And in the hilar areas, you can find increased radiopacity. So hilar lymph node enlargement or hilar adenopathy is evident in this particular chest radiograph. So diffuse infiltrates with hilar adenopathy is the radiographic presentation, chest X-ray of this particular patient. And on right side, you can find the MRI of brain and the area where I'm highlighting. So this is the infarct of basal ganglia. So you can find numerous infarcts in basal ganglia region. So you can in fact make a note of this point because all of these points are associated with your diagnosis. They help you in establishing a diagnosis. So in case of chest X-ray, you can find bilateral hilar adenopathy, lymph adenopathy. And also you can find diffuse patchiness bilaterally. So diffuse infiltrates. That's a radiographic presentation. Also MRI, we're talking about basal ganglia infarcts. So these are radiological findings. And lab analysis or lab findings, you have the following information. You refer the patient to physician. So we advise the following tests, and these are the findings. CSF glucose is 25 milligrams per deciliter, and the protein content is around 80 milligrams per deciliter. CSF fluoride is 95 milliequivalents per liter. Also, you can find the normal ranges for sake of comparison in the brackets, which are in normal font. They're not in bold. So this is the information you have related to this case or related to this context. So which one do you think is a more appropriate answer when it comes to diagnosis? So before you answer that question, I'm going to give you some options. Anil has already pointed out about miliary TB, miliary tuberculosis. So anyways, before we go ahead with our questions, set of 5 questions, I want you to just check out the context once again, carefully. HIV positive male patient with the chief complaint, intraoral examination reveals ulcer on tongue. I'll give you the illustration a bit later. No pain, enlargement of submandibular lymph nodes, headache, fever, and stiffness in neck. Chest radiograph or chest X-ray reveals diffuse patchiness, radiopacity, and also bilateral hilar radiopacities or adenopathy. And MRI of brain reveals infarct in basal ganglia region. You can find these radiopacities. And you can make out a normal from an abnormal by thorough examination of normal and comparing it with abnormal. So before I posted these radiographs, MRI as well as chest X-ray, I even looked into the normal chest X-ray of lungs of a normal person. So once you start comparing normal with abnormal, then it will be easy for you to identify the anomaly and also remember the same in an effective fashion. And lab investigation reveals the following. CSF glucose is less, CSF proteins seem to be increased, and CSF chloride levels are also comparatively less. So this is the data you have. Which one do you think is more appropriate diagnosis? Fungal meningitis, carcinomatous meningitis, tuberculous meningitis, subarachnoid hemorrhage. See, along with radiological information, radiographic presentation, along with chief complaints, also in such cases, we go with a microbial evaluation, microbial culture. So for microbial culture, we use Gill-Nielsen staining, acid-fast staining. To detect acid-fast bacilli, we can go with gram staining. We can go with India in preparation to detect fungi. We can even go for, we have to go for even antigen testing to find out Cryptococcus neoformans. So microbial cultures also should be performed. And even though they are time-taking, the results are time-taking, they help us in establishing diagnosis and providing appropriate treatment. So based on chest radiograph, based on hallmark clinical symptoms, and also intraoral presentation with clinical signs such as submandibular lymph node enlargement. We don't have a biopsy report, but you clearly have the CSF protein, CSF glucose, and CSF chloride levels, which are fluctuating. In fact, as one of you rightly pointed out, glucose levels are low in CSF, protein levels are increased. So what do you think is the most probable diagnosis? Hello, Dr. Nidhi, glad to hear from you. I really appreciated enthusiasm. Dr. Nidhi is one of our previous aspirants who cracked entrance and is right now into her post-graduation. Good. Payal, Sidra, Shubhangi, Hadi, Shailaja, Rishikesh, Vinita, Nabila, Arshish, Smriti, Danish, Priyanka, Ritu. It's good to see that so many of you are giving out answers. So active participation and engagement through notes preparation, of course, is very much essential for learning process. So based on hallmark clinical features, symptoms, clinical signs and symptoms, radiographic presentation, and lab analysis, as you all rightly pointed out, tuberculous meningitis is more appropriate answer. Let me give you some additional information regarding the same. In fact, tuberculosis is one of the most challenging diseases, bacterial infections, challenging diseases to treat for two reasons: persistence and resistance. It persists, right? It is like it causes chronic inflammation and it sequesters itself. It's very much difficult to eliminate this infection from the body. So persistence of this infection and also resistance. In fact, you might have heard of enhanced resistant strains of mycobacterial tubercular species. Also you might have heard of multi-drug resistant tubercular bacilli. So persistence and resistance are two reasons which are cited, like for why we're seeing a difficulty in treating tuberculous cases. So always keep those two aspects in mind. And just because tuberculosis is seen in certain individuals, it doesn't mean that rest of the individuals in the world are free from these mycobacteria. In fact, many of the individuals have this bacteria well within them, but they're mostly carriers. So this is something which is very interesting. So let's go through some information. Tuberculosis is highly prevalent global human infection, which is caused by Mycobacterium tuberculosis, or in short form, MTB. 1/3 of world's population, according to one of the articles, is infected with latent tuberculosis. These individuals, however, are not clinically affected, but carry a lifetime risk of 10% for developing active disease. The best example which I can give you is immunocompromised situation or condition such as HIV. So in this particular context, we have seen that the patient is HIV positive, which means there is a greater chance for developing various opportunistic infections, including tuberculosis. That also should give you a hint, right? So clinical presentation of tuberculous meningitis. So we have these important signs such as stiffness in neck, headaches, fevers. So tuberculous meningitis, this can occur as a sole manifestation, or it can be as a consequence of other areas infection. Like it can occur as sole manifestation of tuberculosis or concurrent with pulmonary or extra-pulmonary sites of infection. Tubercular meningitis, in short form TBM, has high rates of mortality and morbidity, particularly among patients co-infected with HIV. So delay in seeking medical care, diagnosis, and initiation of treatment are contributing factors to high mortality and morbidity, especially in resource-limited regions such as third world countries, including Philippines, Vietnam, China, India. So some of the articles which were old, they mentioned even these countries. Even now, tuberculosis, it's widely seen in our country, in India as such. So it can be attributed to socioeconomic situations, right? It can be attributed to rampant use of antibiotics, lack of proper compliance with the drug treatment, which can lead to development of more resistant forms. So there are so many factors responsible for perpetuation of tuberculosis. So patients with tubercular meningitis develop typical symptoms and signs of meningitis, including headache, fever, and stiffness in neck. In fact, when I was in my post-graduation, I developed stiffness in my back because I used to drive to my college on bike, which was around 30 to 35 kilometers. So daily I had to travel 60 to 70 kilometers on my bike. So lack of back support, I started developing back pain, and I used to have early morning stiffness in neck. So since my college is associated with a medical college, dental college associated with medical college in my post-graduation, I consulted with one general physician with the chief complaint of stiffness in neck. The first and foremost thing he uttered from his mouth is tuberculosis. I was very much worried, but luckily it has something to do with lack of back support and prolonged driving. So I was ruled out. In fact, they have done tuberculin test, the patch test as well, and it came out negative. So I was lucky. I was even advised a radiograph, a chest X-ray, and they ruled out everything in line with diagnosis of TB. So my point is stiffness in neck is very, very important. Stiffness, the word itself should give us a clue, but stiffness doesn't always mean tuberculosis, as in my case, right? So what is the most probable diagnosis given the clinical signs and symptoms, given the radiographic presentation, given the lab finding? It is tuberculous meningitis. In fact, we can rule out fungal meningitis, of course, through radiological examination, also through microbiological culture. So with India in preparation, we can identify fungi and we can rule out fungal meningitis. Carcinomatous meningitis, biopsy would be definitive. We can rule it out as well. Subarachnoid hemorrhage, yes, MRI, there can be overlap also in subarachnoid hemorrhage. There will be drop in CSF glucose levels and elevated proteins, but other signs and symptoms associated with subarachnoid hemorrhage would help us distinguish the same from tuberculous meningitis. So tuberculous meningitis, we have these hallmark clinical signs and symptoms, which should make the diagnosis quite easy for an experienced physician, right? I hope it's clear. So as majority of you, yeah, as rightly mentioned, in fact, all of you have chosen option C. Well done, keep it up. Anil Kumar says, it's the next question, please go to sleep. If you want to sleep, you should sleep, Anil Kumar. You should never sacrifice your sleep for sake of a session, because this session can be watched again tomorrow or infinite number of times from tomorrow, right? Once you get restful sleep. But if you're sacrificing your sleep for sake of session, I would never suggest you to do so, okay? So if you're in a hurry or if you want to sleep quick, then I suggest you to go ahead, sleep now without waiting for us. So the rest of us will go ahead with our interaction as usual. Okay, yeah, go ahead. So this anonymity over internet gives each and every one of us this extra superpower to say anything we want to. There are certain things which we would never dare to say on face of a professor, especially in an offline class. But this online mechanism gives this enormous power, right? To say anything to anyone, which is good to some extent, but at the same time, it has its own drawbacks. You'll know once you face it. So second question, a related question, hallmark findings in CSF of patients with tubercular meningitis include which are the following: low glucose levels, high protein levels, pleocytosis with lymphocytic predominance, all of the above, none of the above. So which one do you think is more appropriate answer? In fact, I've seen a couple of questions related to low glucose levels. So whenever there is any kind of infection, or even in case of cancers, even in case of fungal infections, any kind of infection in general, glucose levels are comparatively low in CSF. Previously, they thought like since bacteria or microbes are present, they need energy, so they utilize glucose for glycolysis and then try to obtain energy, the bacteria in CSF, and that could be one of the reasons, or that could be a reason for low glucose levels. However, this is no longer considered to be the only factor responsible for low glucose levels in CSF. There are other reasons for low glucose levels in CSF, especially in cases of infection. So, what are those reasons? In fact, that's one of your homework questions, so try finding out. So, which of the following is hallmark finding in CSF of patients with tubercular meningitis? So, which one do you think is a more appropriate answer? So low glucose levels, high protein levels, pleocytosis is the increased number of cells with lymphocytic predominance. See, chronic, right? Tuberculous, it is almost synonymous with chronic infection. So all of the above, as majority of you rightly said, is the right answer. If the clinical presentation is suggestive of tuberculous meningitis, as just we have seen in this particular context, CSF should be sent for routine analysis. That is cell counts and differential, protein level and glucose level, and microbiologic tests of bacteria, fungi, and Mycobacterium tuberculosis should be performed. Pleocytosis with lymphocytic predominance, as you can see in the options, high protein levels and low glucose levels are the hallmark findings in CSF of patients with tubercular meningitis. So all of the above is appropriate answer. Very good, well done. Do award yourself +4. So you have the scoring system. At the end of the session, you can reveal your score out of 20. So you have 5 questions, 5 4s, 20 is a maximum score. Now let's move on to the next question. True about tubercular lesions in oral cavity. The patient's chief complaint in this particular case or context is ulcer on tongue. So I hope you have noticed it. So which of the following is true about tubercular lesions in oral cavity? Option A, tongue is most commonly affected. Option B, oral lesions may be present as ulcers or nodules. Option C, ulcerative form is the most common presentation. Option D, deeper biopsies are always advocated for ulcers of the tongue if you suspect that to be a tubercular lesion. All of the above, none of the above. So which one do you think is more appropriate answer? It seems I've done your job pretty easy. I've simplified your job of answering questions by providing you all of the above and none of the above. So anyways, so which one do you think is more appropriate answer? As majority of you have rightly chosen, all of the above is right answer. Can anyone give me the reason for option D? Like I mentioned that deeper biopsies are always advocated for ulcers of tongue. Why not superficial biopsy? Why should we go with deeper biopsy? Any hint or clue? See, first of all, there are several areas in oral cavity which can be affected. So oral TB lesions, either can be primary or secondary. Oral tubercular lesions may occur at any location of oral mucosa, but the tongue is most commonly affected. Other sites include palate, lips, buccal mucosa, gingiva, palate and tonsil, floor of the mouth, salivary glands, tonsil, uvula, literally all regions in oral cavity except for teeth. Primary oral tubercular lesions can be present as painless ulcers for long duration and enlargement of regional lymph nodes, all of which have been clearly mentioned in your particular context. Patient had ulcer for quite a long duration, for several months, he says. And clinical sign is submandibular lymph node enlargement. The oral lesions may be present in a variety of forms such as ulcers, nodules, tuberculomas, or periapical granulomas. The ulcerative form is the most common, as mentioned in one of the options. And when oral tubercular lesions occur as a primary lesion, an ulcer is the most common manifestation, usually developing along the lateral margins of the tongue, which rest against sharp or broken teeth or the site of other irritants. So this is some information which we have related to tubercular lesions in oral cavity. And all of the options are right answers, and superficial will be contaminated with normal cells and will give false negative. Good, Anil. Good, Naveen. Yeah. we need deeper biopsies because superficial ulcers may not reveal the etiological agent, that is the bacilli, and also there is epithelial hyperplasia superficially. So for these reasons, we need deeper biopsies in order to study the ulcer of the tongue. Very good, Anil and Naveen. Well done. Now let's move on to the penultimate question. Before that, this is a clinical picture you have. So ulcer on tongue, painless ulcer in case of tuberculosis, one of the oral manifestations. So tongue is the most common site where you find these lesions. Yes, Arshi. More than 3 weeks, yes, we have a criteria. Yes, we suggest a biopsy. Good. Now let's move on to the penultimate question. Which of the following drug is not a first-line drug for treating tubercular meningitis? You know, we have these basic drugs, right? Isoniazid, rifampin, ethambutol, streptomycin. So we have these various drugs, combination of drugs, multi-drug regimen for treating tuberculosis, as you all know. In this context, we're talking about TBM, that is tubercular meningitis. So which of the following is not a first-line drug for treating tubercular meningitis? Let's see how many of you are going to get it right. Pyrazinamide, isoniazid, dexamethasone, rifampicin, all of the above, none of the above. So which one do you think is more appropriate answer? You might have heard of all these names. So which one do you think is more appropriate answer? I see a split in choice of options. A majority of you are going with option C, and some of you are going with option E. Preeti has chosen option D. Very good. Almost all options are being covered. Well done. So anyways, which one do you think is more appropriate answer? So which of the following is not a first-line drug for treating tubercular meningitis? None of the above. Danish seems to be very excited to choose option F. Dwypoin also. Yeah. Dexamethasone, C, is it a steroid? You shouldn't be asking me, Anil, you should be telling me. Yes, Sidra, this is definitely true. It's like a group approach. So each one choose one particular option. One of you will be definitely right. So it's definitely a wonderful group approach and group strategy. Yashika says dexamethasone is never the first line, but unfortunately, it is in case of treating tubercular meningitis. So as Danish rightly pointed out, none of the above is right answer. Before I know you'll be surprised, but let me give out some information. According to guidelines provided by British Infection Society and also WHO recommended guidelines and also guidelines laid down by Government of India, we have all these references which we'll be sharing along with this live video in e-classes. Adjunctive corticosteroid therapy or adjunctive corticosteroids reduce the risk of death or disabling a residual neurological deficit from tubercular meningitis. So it reduces a risk of death. We can make a note of this point. And according to the information which is available in our government website, we found out that this steroid is recommended for TB meningitis in HIV negative people. And the duration of steroid treatment should be for at least 4 weeks with tapering as appropriate. Also, the website clearly says, the file clearly says that steroids may be used for TB meningitis in HIV positive people also where other life-threatening situations or opportunistic infections are absent, right? Which means dexamethasone is also a first-line drug for treating tubercular meningitis, according to the reference articles which we have. and also according to the information provided by various official websites, including the Government of India website on guidelines on extra-pulmonary tuberculosis for India. So in collaboration with WHO, they have released the following information. So you can make a note of it. Okay. So dexamethasone also falls under first-line drug for treating tubercular meningitis. Consider this very, very important. So if you're expecting me to provide you ready-made, easy answers in every slide, then you'll fall in soup for sure, just like you did in this particular slide. So adjunct to corticosteroids reduce the risk of death and or disable residual neurological deficit from tubercular meningitis. Also, in HIV patients who are having this tubercular meningitis, they have this propensity to develop an intense inflammatory reaction upon administering antiviral therapy. And this intense inflammation has to be managed and can be managed using steroids. So this is additional point. So we'll anyways discuss this in the next slide. So option F is a right answer. Sidra also chose option F. Very good. Yashika, no, it's not that after first-line drug we prescribe this dexamethasone. According to PubMed indexed article we have, in that they have clearly mentioned, given out a table, first-line drug regimens for tuberculous meningitis. So you can check out this particular table. So we'll be sharing this table in our e-classes. So the first-line drug regimens for tuberculous meningitis. So I'm reading it out for Yashika. It's isoniazid, rifampicin, pyrazinamide, ethambutol, streptomycin, and dexamethasone. Dexamethasone should be given intravenously at first and then orally as tolerated. Dosage should be tapered weekly. So we're providing you multiple references so that you will not have any confusion. Now let's move on to the the final question, ultimate question of this session. HIV-infected patients receiving treatment for tubercular meningitis are at risk for clinical deterioration after initiation of antiviral therapy or antiretroviral therapy due to which of the following? Immune reconstitution inflammatory syndrome, immune resilience infection syndrome, isolated reinfection injection syndrome, intracranial rejuvenation inflation syndrome. So which of the following options is actually making sense to you? HIV-infected patients, as in this particular context, receiving treatment for tubercular meningitis, again, as in this particular context, which we have been discussing from the beginning, they are at increased risk for clinical deterioration after initiation of ART, that is antiretroviral therapy. Why? What do you think is the reason for the same? So treating the patient for antitubercular meningitis, right? So you're instituting the following drugs, isoniazid, rifampicin, and all, and also you provide them with antiretroviral therapy. So what can you anticipate among the following? Which one do you think is more appropriate answer? The short form is IRIS. So what does IRIS stand for? In fact, you can find out IRIS in one of the options here. As majority of you have rightly chosen, yeah, we'll go with it. So HIV-infected patients receiving treatment for tubercular meningitis are at risk for clinical deterioration after initiation of antiretroviral therapy due to immune reconstitution inflammatory syndrome. Option A is the right answer. And also because of this, steroid has to be given to manage this particular condition. So yeah, immune reconstitution inflammatory syndrome, or IRIS in abbreviated terms, the rapid restoration of immune function in the presence of mycobacterial antigens provokes an intensified inflammatory reaction, resulting in worsening, recurrent, or new clinical signs and symptoms. It's very simple. Patient has HIV, his immune cells are deteriorating, they're dropping down, and he has this opportunistic infections like tuberculosis, tubercular meningitis, you're treating him. So when you institute antiretroviral therapy, so you're trying to enhance the patient's immune response. So in that process, there can be intensified inflammatory reaction between this enhanced immunity and the existing mycobacterial products, leading to this immune reconstitution inflammatory syndrome, which can intensify the existing clinical signs and symptoms, which can be managed again with corticosteroid treatment. Okay, so just make a note of this particular point. And as majority of you have rightly mentioned, option A is right answer. And if you're not answering, not taking the risk, then you'll be getting 0, which is better than -1. Good. So these are the following homework questions you have. Number 1, what is DOTS? Dots. Number 2, dental healthcare professionals. In our context, they're at constant risk of getting exposed to TB. What could be the source? Just don't say patients. I mean, if patient has TB, does it mean it will be transmitted to us directly? If yes, how? Or are there any other means through which we can contract tuberculosis in a dental setup? And third question, what is the cause for hypoglycorrhachia? Right? Hypoglycorrhachia. So what is this hypoglycorrhachia, and what are the causes of this hypoglycorrhachia? So try finding out 3 homework questions and get back through mail. We'll provide you key after verifying your answers. If you're getting back with right answers, you will not require a key, but if you go wrong somewhere, we'll definitely update your work with relevant key. Okay, just like how we have been doing for the past 2 weeks. So I hope it's clear. Yes, very good. So I really appreciate your active participation. All you need to do is just maintain this momentum, maintain this consistency. Check out those homework questions, get back through mail. And if you have any further questions, you need any further clarification, feel free to get back through mail 24/7. As I said, learning, unfortunately, is being considered as a sort of punishment. In fact, if you carefully observe, if you're doing it consciously, you're going to learn so many things which are going to help you tremendously in your clinical practice. And also, if you come across any patient with the following signs and symptoms, you cannot say, no, I don't know, I can't deal with it, I don't deal with it, and just push the patient to physician. Even if you have to refer the patient to physician, you must know when to refer a patient to a physician. And if physician provides a consent, if they advise some lab tests, some chest x-rays, yes, he or she will take care of the diagnosis, and the patient comes to you again. If the patient shows you a chest x-ray, if the patient shows you an MRI scan, if the patient shows you his or her lab report, at least you should be able to correlate that clinically, analyze the situation, and of course, treat accordingly. If you know that the patient is being treated with tubercular meningitis, you look into the drugs which he or she is taking. And there are many antibiotics or dental-related drugs, analgesics, which have potential interaction with these anti-tubercular drugs. There can be diminished functioning of liver. There can be effect on kidneys, nephrotoxicity. So we cannot say that this is not in our domain. Tubercular treatment or any kind of treatment which is being dealt by the physician, we cannot say, our dentist cannot say that it's not in our domain, because we're ultimately treating patient. Even though we confine to oral cavity or oral maxillofacial region, the body as such is a single unit. So if you're treating one particular ailment and patient has a general ailment, there is some sort of link always, without any doubt. So one of the objectives of this case-based discussions is to make sure that we're familiarizing ourselves with various basic concepts, including the topics from general medicine and general surgery. And along with that, obviously, in recent entrance examinations, NEET MDS, we're having several case-based discussions along these lines. So keeping these aspects in mind, we're doing these case-based, made easy live discussions And I hope you're enjoying them. And most importantly, I hope you're enjoying the process of learning, which is very, very important. If you're not enjoying, if you feel like sleeping, if you feel like, why should I do this? Then there's no point in doing it. So I hope you got my point. And you have any questions, you need any assistance or clarification, always feel free to get back through mail 24/7. So wish you all the best. Love you all. Good night. Yeah, Ritu, Payal, Smriti, very good. So if you have posted your scores, it definitely is an indication that you at least feel like you've done extremely good. So well done, keep it up. Yeah, systemic inflammatory response syndrome, SIRS. Yeah, that is something which we dealt with in our e-classes also in YouTube, I reckon, so you can check it out. So why did Smriti mention about SIRS? Yes, Yashika. Yeah, the letters are the same. If you observe iris and yeah, SIRS, the letters are the same, but their arrangement is different. Okay, very good. And also Sidra has mentioned, Nabil also got 15, very good. Very well done. So it's not easy to score 15 in this particular session. Even though I've incorporated some challenging questions, especially the penultimate question, you still did good. Some of you even answered the fourth question right. I really appreciate your enthusiasm. And yeah, in fact, Sidra has mentioned that she hasn't taken the risk by answering a question. That is very, very important because 0 is far better than -1. So always keep that in mind, especially when you're dealing with entrances which have negative marking, such as NEET, including ini-cet, 1/4 and 1/3 negative marking respectively. Okay. You're welcome, guys. So love you all. Good night. I'll see you again tomorrow in 9:30 p.m. session in next case-based discussion. Take care.